Let me know when it's time to start.
Go for it, Dr. Sabiri.
Good afternoon, ladies and gentlemen. On behalf of the organizers of this grand round, I'd like to thank you for taking the time out of a busy day to join us. My name is Asif Saberi. I'm by training a pulmonary and critical care physician. I'm also the medical director of critical care and ECMO at Wellstar Kennestone Hospital. As of yesterday, there were 3.25 million of patients who had been diagnosed with COVID-19 worldwide, with almost a third of those occurring within the United States. There have been more than 230,000 deaths worldwide and more than 60,000 in the US alone. Yesterday, more than 2,500 Americans died due to COVID-19. You will agree that this is a defining moment for critical care, and indeed for all of medicine. For many years in the future, each of us will remember the 2 months of the spring of 2020. Everything moved fast during this time. The pandemic progressed and we kept pace, learning new things quickly and adapting. We challenged existing notions and assumptions, including some about the safety of our patients. In just a few weeks, we learned that the principles of ventilator management that had been sacred for a couple of decades could be challenged by the unusual manifestations of this disease called COVID-19. Some of the things which would have made us shudder in the past were the very things that we had no option but to adopt. We moved ventilator screens and IV pumps outside patients' rooms. We prepared non-critical care physicians to take care of critically ill patients. We created ICUs out of new areas. Some of us at least thought about using a single ventilator for more than one patient. Regulatory bodies put aside rules to accelerate the process of approving treatments that in the past would have taken months and years to approve. Our language has also evolved and includes many terms and many new terms and some that were not commonplace in the critical care lexicon. We have H phenotype and L phenotype. We now talk about cytokine storm. We talk about microvascular thrombosis. And in desperation, we have clutched at straws in prescribing unproven treatments. But we also broke and will continue to break some barriers that had bogged us in the past. You must admit that healthcare will never be the same again. Our understanding of COVID-19 is evolving. A necropsy study recently suggested a bimodal disease paralleling the bimodal pattern we observe clinically. In early disease, histopathology showed a pattern of diffuse alveolar damage that is consistent with ARDS. However, those patients who died 20 days or later into their presentation had extensive intraalveolar fibrin balls. They also showed intraluminal loose connective tissue within bronchioles and alveolar ducts, and a lack of hyaline membrane, features not characteristic of ARDS. Additionally, there was vascular injury, including the detachment of endothelium in small and medium-sized vessels. This is not dissimilar to the histopathology seen in severe acute respiratory syndrome, also known as SARS from 2003, or the Middle Eastern Respiratory Syndrome, or MERS, both coronavirus diseases. What is different from ARDS is that these patients demonstrate a lack of pulmonary vascular constriction seen with hypoxia. These grand rounds will attempt to bring to you some practical considerations in the management of your patients with COVID-19. 3 such sessions are planned. In today's first session, our faculty of recognized physicians will discuss with you the management of critically ill COVID-19 patients. Future sessions will focus upon disease-specific management and treatment, as well as testing and immunology. A couple of words about this session. During this session, the audience is muted by design. However, you can interact with the faculty using the chat box. Your questions will be screened by moderators and forwarded to me to present to the faculty at the end. and those of you who registered will receive instructions on how to claim CME credits. Before we start, I do want to acknowledge a few individuals. Dr. Amy Case, who conceived of the notion of bringing physician leaders in the Atlanta area together to collaborate in response to the COVID-19 pandemic, Michael O'Toole for facilitating our meetings, and John Heisler and Nandita Jacob for helping with organizing the grand rounds. Let me start by introducing our first two speakers. They will be talking about hypercoagulability of COVID-19. Dr. Charles Ross is by training a vascular surgeon and is the Chief of Vascular and Endovascular Services and the co-director of the Piedmont Heart Institute's Level 1 Cardiovascular Emergency Program. He's a distinguished fellow of the Society of Vascular Surgery. His special interest is in venous thromboembolism, and he is credited with helping galvanize the medical community of Atlanta to develop local PE response teams in each of their facilities. Our second speaker on this topic will be Dr. Manila Gad. Dr. Gad is by training a hematologist and an oncologist and is the Associate Professor of Hematology and Oncology at the Emory University School of Medicine. She's also the Director of Hematology Consult Services at Emory and the lead thrombosis physician at the Hemophilia of Georgia Center for Bleeding and Clotting Disorders at Emory. Ladies and gentlemen, Doctors Ross and Gad.
Just trying to get the screen set up here. Having a little trouble with Zoom here. Here we go. Thank you, Dr. Saberi. And I want to thank the organizers for giving us this opportunity to begin the session. I'm really excited to be paired with Dr. Gad from Emory. She and I have worked in the realm of pulmonary embolism for the past 4 years and have really had a lot of collegial relationship in that area. Now, I don't have any disclosures or conflicts to in the realm of pulmonary embolism for the past 4 years, and I have. Sorry, guys. All right, now we can hopefully get started. Anyway, here to talk about COVID-19. And when we begin to talk about COVID-19, we have to first recognize the evolving understanding of the importance of thrombosis and hypercoagulability in this disorder. So we have a number of observations to talk about. Number one, most COVID-19 patients are either asymptomatic or have mild symptoms, but those patients that are critically ill manifest a severe inflammatory response, and that has associated endothelial damage, end-organ microthrombosis, and also is associated with macrothrombosis. Now, mortality in COVID-19 patients has been associated with markers of thrombosis, like an elevated D-dimer, and this can occur with or without large vessel thrombosis. Limited data suggests that these markers, when they're elevated, are strongly associated with mortality. And yet when you treat the patient with anticoagulation therapy, one sees a decrease in D-dimer, levels, and this implies some moderation of the prothrombotic state. Patients treated with anticoagulation have been shown to have lower mortality. Given the novel status of COVID-19, these observations have really important clinical implications. Basically, that anticoagulation management may reduce the morbidity and mortality of COVID-19. Let's talk a little bit about the overall picture of thrombotic perturbations with COVID-19 and how it relates to outcomes. The first thing about COVID-19 to realize or think about is that the patient comes with their own pre-existing risk factors. And these that are really important in COVID-19 include hypertension, smoking, existing coronary artery disease, previous stroke, also age and gender, presence of diabetes, obesity, cancer, and immobility. Now, a lot of these factors you will recognize are risk factors for VTE in our normal patients. Now, in COVID-19, the specific pathophysiology of the disease itself is very pro-inflammatory. Cytokines are released, endothelium is damaged, a prothrombotic state begins, there's increasing circulating thrombin, platelets aggregate, and if this thing's allowed to spin out of control, one gets into consumptive coagulopathy and DIC. This is manifested in the patient in many ways, but we see dehydration, immobility, sepsis, hypoxemia. Patients go on mechanical ventilators, they become shocky, they have intravascular lines and devices. And all of these things contribute to the risk of mortality in the patients. And macrovascular thrombosis as well as microvascular thrombosis are part of that cycle. Now, laboratory markers that may be seen, which are associated with worse outcomes in COVID-19, include some cellular markers like lymphopenia and thrombocytopenia, and biomarkers like LDH, D-dimer, C-reactive protein, ferritin, and IL-6. Tang has looked at this with an experience of 183 patients from Wuhan, of which 21 people died. And in the non-survivors, elevated D-dimer, elevated fibrin degradation products, elevated ProTime, and multiple factors meeting the criteria for DIC were seen in the non-survivors. And among these markers, thrombocytopenia and an elevated D-dimer were the most important. Clinical manifestations of thrombosis and DIC may be evident, like pulmonary embolism and deep vein thrombosis. The signs and symptoms of these illnesses may be seen on rounds and in the clinical patient. Arterial manifestations include myocardial infarction, stroke, acute limb ischemia, and even digital ischemia. Microthrombosis may be implicated in the pathologic features that we're seeing in the lung, the kidney, multiple organs, and even as recently as today reported in the placenta. Now, the incidence of thrombotic complications in critically ill patients with COVID-19 has been reported by Clock from the Netherlands, looking at 184 consecutive ICU patients. Of these, about 31% of the patients had a thrombotic disorder that was clinically identified. 27% had VTE, and among the VTE, most of the patients actually had pulmonary embolism. 4% of the patients had arterial thrombosis. So it stands to reason that if thrombosis is so important in the pathophysiology of COVID-19, there ought to be a rationale, or there is a rationale for anticoagulation therapy. And there are some steps that can be taken to develop a logical approach to anticoagulation therapy in these patients. The first step is to stratify the patient's baseline risk for thrombosis. And you do this for every single patient you admit to the hospital. One looks at age and functional status, comorbidity, markers of risk like the Caprini score or the Padua score or the IMPROVE score. One may look at laboratory markers with a D-dimer greater than 3,000, recognized by many centers as being very important. And then the clinical status at the time of admission, one needs to look for signs of established venous thromboembolism. Now, as the patient evolves through their illness, they may become more and more ill, and you would need to re-stratify their risk because that may affect how you manage their anticoagulation. And then the final thing you need to do is to assess and reassess their risk of bleeding, looking for thrombocytopenia, any sign of coagulopathic bleeding, concurrent organ failure, like kidney failure, which may affect how we manage their anticoagulants, and then any recent bleeding events. But the take-home point is to assess the patient along these lines every day, even multiple times a day, if the patient deteriorates, and then to escalate therapy as appropriate. Now, we have some general guidelines for managing anticoagulation therapy. And the first thing to remember is that any COVID patient that comes into the hospital should be given at least baseline prophylactic anticoagulation unless there is an absolute contraindication. You also want to use mechanical devices like your intermittent compression devices. Low molecular weight heparin is the agent of choice. And in these patients, you want to check anti-10A levels to make sure you're achieving targets as shown here. As a patient becomes more ill with worsening respiratory status, elevated D-dimer, sepsis, worsening Caprini score, even in the absence of no identified thrombus, you may want to escalate their anticoagulation therapy to a low molecular weight heparin at 1 milligram per kilogram per day. And you can give that as a daily dose or a divided dose. You ought to check a target anti-10A level, and that should be between 0.3 and 0.6. Now, there's a little bit of controversy here, and some authorities are saying that they would go to therapeutic anticoagulation in this group, especially if you're seeing further deterioration of the patient. But right now, we're using an intermediate risk as a or an intermediate dosing strategy to handle these patients. Now, finally, there's your high risk group. And this is the group that's easiest to think about because these people have already been identified as having established DVT or PE, and you treat them with regular therapeutic anticoagulation therapy like low molecular weight heparin at 1 milligram per kilogram every 12 hours. Excuse me. Now, there are special circumstances in the obese. You want to weight adjust your low molecular weight heparin. If the GFR is less than 30 cc's a minute, you would want to switch to unfractionated heparin. And patients that are on anticoagulation therapy at the time of admission for things like AFib and established VTE, you certainly want to continue that therapy. There's a misperception out there that you might have to change that therapy, but you really do not. You need to continue it. Now, finally, I want to talk a little bit about extended duration anticoagulation therapy at discharge. The rationale for this is that COVID-19 patients ready for discharge are recovering from acute medical illness, often severe. And so VTE has been a real threat to those patients during hospitalization, And in many of the people, it's going to continue to be a threat after their hospitalization. So there are some general considerations. The first thing to know is that the risk of developing clinically significant VTE or arterial thrombosis after discharge is unknown. Right now, we don't know how many patients are coming back having been free of VTE at the time of discharge, but developing it after discharge. We just don't know. And so there's no evidence base guiding discharge anticoagulation practice for COVID patients. What we're doing is extrapolating our knowledge of managing non-COVID medically ill patients. I think in this group, our biggest concern is patients that are already at high risk for DVT, both in the hospital and at the time of discharge. And these would be identified as having an elevated D-dimer of 3,000 at the time of discharge, elevated Caprini score. They might be immobilized, they might be morbidly obese, and they might be recovering from having been supported on ECMO. The decision to treat requires risk-benefit assessment. You really want to assess the bleeding risk. You want to think about what other medicines the patients are on and assess drug-drug interactions. It's a shared decision-making process. One needs to talk to the patient to make sure they're comfortable going home on an anticoagulant, and that they're going to follow up with their primary care physician. And then finally, you want to set up that close outpatient follow-up. Now, I'm sorry about this slide. It's obviously difficult to read, but I don't think I need to reemphasize what I've just said. The one thing I want to tell you is that multiple societies have now promulgated algorithms for management of patients at discharge. The algorithm here is suggested by the American Venous Forum. It's available online and will be available in our slides. That'll be available at the end of this session. So with that, I'll turn it over to my partner, Dr. Gadda, and thank you very much.
Hello, everyone. Just trying to figure out how to share my screen.
As we wait for Dr. Gadd to bring her screen up, there she is.
Yes,
All right.
I am here still, however, figuring out how to bring the screen up.
I got it for you, Dr. God.
Okay. All right. So can you hear me?
Yes, we can hear you.
Okay, perfect. All right. So if we can just move to the next slide. Okay, here we go. All right, so thank you, Dr. Ross, and thank you everyone at the organizers and my co-presenters for putting this together. I apologize for this technical glitch here. These are my disclosures. Okay, so moving on. I think Dr. Ross has made a very good case about considering anticoagulation in all admitted patients with COVID-19. Now, this leads us to our next question, which is anticoagulation enough? And this question leads to more questions than answers, just because of limitation of our understanding of the hypercoagulability mechanism and management in COVID-19 patients. So what we know about critically ill COVID patients is that even on pharmacologic thromboprophylaxis, and this is a Dutch series that stated that the incidence of symptomatic thrombosis is around 31%. Can you hear me now? I got a message saying.
No, we can hear you fine. That must have been
Okay. I see. Okay, sorry. So the Dutch series says there is symptomatic thrombosis is developing in 31% of patients, even when they are on some degree of thromboprophylaxis. And VTE from this was 27%. A more systematic review of patients by the French showed that when lower extremity duplex ultrasound is done in all COVID-19 patients in the ICU, and chest imaging for PE is done in all patients with persistent hypoxemia or secondary deterioration, then up to 56% of these patients, even on therapeutic anticoagulation, developed VTE. Okay. What we have learned from the first autopsy series that has come out in COVID-19, and which is similar to the findings that were seen in the SARS-CoV-1 cases, is that there are thrombi present within small vessels in the lungs on gross examination. And next. And even on a microscopic examination, there are extensive extracellular fibrin deposition and intravascular fibrin thrombi that are seen in these patients. Again, indicating perhaps it is these clots that are playing a role in mortality here. Next. So how do we measure success of anticoagulation in these patients? I think points to understand are that just other than VTE, arterial thrombosis, there are organ dysfunctions that we believe are related to microthrombi. What we are seeing is that ARDS in these patients has a different behavior. CRRT lines are clotting and reclotting despite routine and escalated prophylaxis. There are otherwise stable patients who are suddenly decompensating. And again, multi-organ failure is also raising concern for microthrombosis as an underlying mechanism. In our other run-of-the-mill VTE, arterial thrombosis studies, it's easier for us to set outcomes of study. But here, when we're talking about multi-organ failures, what would be the real outcomes that will tell us whether anticoagulation is successful or not? Is it improvement in vent settings, number of days they're intubated, number of days they're requiring dialysis? So that's another question that remains unclear. Now, central to this refractory kind of hypercoagulability in COVID-19 patients is this concept of thromboinflammation that Dr. Ross alluded to earlier. So what happens is the primary infection initiates organ injury, say in this example, I'm talking about alveolar injury, this causes an inflammatory response, which damages the capillary endothelium. Now, our endothelium is an important part of both our anti-inflammatory and antithrombotic syndrome systems in the body. When this endothelium is damaged, it kind of lets the floodgates loose. This causes activation of the coagulation cascade, activation of complement system, a thrombotic microangiopathy kind of a picture, further recruitment of platelets, immune cells, which causes microvascular thrombosis, and ultimately fibrosis, which is damaging for the tissue. Now, this graph here very nicely shows how an adaptive hemostasis response, which is supposed to be protective for our body in the presence of an infection, if left uncontrolled, turns into a thrombotic and further fibrinolytic kind of DIC. So the components of clotting system, most of our blood cells, endothelium, all these are parts of a natural defense mechanism against infections. Even generation of thrombin is meant to limit the infection, catch it right there, nip it in the bud. However, once this goes out of control, then the hyperimmune response and activation of the coagulation cascade causes thrombosis, multi-organ failure, and also perhaps fibrinolysis. And if you look at this closely, the bottom part where these different treatments have been described, heparin, antithrombin, thrombomodulin, depending on which phase of this response the body is in, all of these different therapeutic agents can play a role in management. Next, please. Okay, so now with this background, how do we approach this refractory sort of hypercoagulability in the COVID-19 patients? I think it is important to understand that coagulation cascade is one of the pathways that is causing the inflammatory and clotting response in these patients. So no wonder just targeting the coagulation cascade has its limitations. So what we need to do is identify the etiology and therapeutic targets in kind of individual patients as we manage them. One of the things to consider is heparin resistance, because in these patients, we do see some of these patients have low antithrombin levels, although majority so far in our experience and in hearing experience from our colleagues in Italy have shown a relatively high antithrombin level of 70 to 80% at least. But if you do come across that, then that is a thing to manage. High fibrinogen, high factor VIII levels are other proteins that can cause heparin resistance. And if you see that by way of your anti-10A level testing, then perhaps switching to an alternative anticoagulant or giving thrombate infusion can be considered. Again, there is interest in inhaled heparin for a coagulopathy that is limited to the lungs, manifested as respiratory distress. Attacking platelets. Now, platelets are an important component of the inflammatory and coagulation systems. So, and there is data from studies in sepsis, limited data, but data that suggests perhaps targeting platelets can be considered. Fibrinolytic system, there's concern of sort of a shutdown or hypofibrinolysis occurring in the thrombotic phase of DIC. There are tests available, the viscoelastic tests that have mainly been studied in bleeding patients, but they could have a role in assessing need for either fibrinolysis or antiplatelet therapy in these refractory hypercoagulable patients. Complement cascade, again, by means of initiating a thrombotic microangiopathy kind of a picture, perhaps that is a target that we can consider. Since the implications of these treatments can be grave, it is better if treatments associated with more side effects are studied more systematically in clinical trials. Attacking the endothelium or perhaps the immune system itself by anti-cytokine therapies, suppressing the plasma cells, or considering plasma exchange in select patients. Now, there are case series reported with quite a few of these agents already in COVID-19 patients. But I think what is needed is a more systematic evaluation before it becomes available for routine use or you put in any kind of algorithms. Next, please. So again, clinical trials would be ideal, but they do require more time, more effort. As we take care of these patients in real time, what can we do? It is, I think, absolutely essential to have institutional review teams that can review cases and develop pathways as they go. This is what we're trying to do here as well. It was relatively easier for us to come up with an anticoagulation algorithm, but when we get to refractory patients, it becomes very important to review each refractory patient as a team, learn as we go, and then develop and evaluate our algorithms as we go. One approach could be a tiered approach, meaning you use low risk therapies or easily accessible therapies first. For example, considering antiplatelet agents in patients who are refractory and do not have any contraindication to antiplatelet therapy or escalation of anticoagulation. So, this kind of a tiered approach could perhaps allow us to understand this better and take care of our patients better. Another thing is thinking outside the box. This is a disease that we've not seen before. Perhaps creating and trying low risk regimens of conventionally high risk therapies like fibrinolytics is something that is needed. Next, please. What about DIC? So, what we are seeing is a thrombotic DIC documented in severe disease, but a hyperfibrinolytic, the traditional consumptive DIC that presents with a bleeding diathesis, is rare and seen only in very late stage disease. The laboratory findings that indicate development of and progression of DIC are low platelets, fibrinogen, antithrombin levels, high coagulation assays like PT, APTT, high D dimer, and of course, evidence of microangiopathic hemolytic anemia. And what can we do for these patients? We know that the main treatment of DIC is treatment of underlying infection. The question is, do we have it here in this case? There are trials going on, and hope some of the treatments, as you all probably already know, appear to be promising, but again, more to learn in that respect. Important thing is looking for and treating secondary infections. When you start seeing patients progressing to a hyperfibrinolytic phase of DIC especially, it is very important to make sure there is no other secondary infection that we are missing. Then supportive measures, yes, blood products like platelets, FFPs, cryoprecipitates, if they are below the thresholds and the patient is exhibiting a bleeding phenotype, then these infusions do have a role. Next, please. And to wrap it up, things like antithrombin, antifibrinolytics, they may have a role, however, need very close monitoring with antithrombin for bleeding, and with antifibrinolytics would limit use of antifibrinolytics only to massively bleeding phenotypes at this time. Next, please. Lastly, to sum it up, coagulopathy is common in COVID-19 and probably drives most of the pathophysiology. All admitted patients need some form of thromboprophylaxis weighed against risk of bleeding. Careful escalation of anticoagulation based on clinical and lab parameters appears reasonable. Inflammation drives the thrombotic response, but much about pathophysiology and therapeutic targets, especially in refractory hypercoagulable patients, still remains unclear. Thank you all.
Great. Thank you so very much, Drs. Ross and Gad, for that fascinating discussion about a very important aspect of COVID-19 that we are witnessing. Our next speaker is going to be Dr. Chad Miller. Chad is still texting me his bio. And who know Chad know that he's an incredible guy. But
actually, Dr. Esper is next.
Okay, Dr. Esper is next then. Well, let me introduce Dr. Miller, and then I'll go to Dr. Esper. Dr. Miller is, as far as I know, a pulmonary and critical care physician by training. He had some special training in pulmonary vascular disease and is now the director of Pulmonary Vascular Diseases Program at the Advanced Lung Disease Center of Excellence at Piedmont. At least that's what his signature line says. I know that he is part of the PERT team at Pulmonary at Piedmont Atlanta Hospital and is also involved in multiple trials involving pulmonary hypertension treatment. Our very next speaker is going to be Dr. Annette Esper. The two of them will share the topic of respiratory failure. Dr. Esper trained as a pulmonologist and a critical care physician, and as an associate professor of medicine in the Division of Pulmonary, Allergy, Critical Care, and Sleep at Emory. She's also the section chief for pulmonary allergy and critical care at Grady, and is the associate program director for the training program, the Pulmonary Critical Care Fellowship Training Program. Drs. Esper and Dr. Miller in that order. Thank you so much.
Thank you. Thank you all for having me. Let me go ahead and share my screen. Okay, does that look good to everybody? Okay. Again, thank you for having me. It's been a pleasure working with this group. We're going to change courses a little bit and talk a little bit about the pulmonary disease that we see with these patients that are infected with the SARS-CoV-2 virus. And what the most common and serious manifestation that we see is a viral pneumonia that can be characterized with hypoxic respiratory failure and may progress to the acute respiratory distress syndrome. And it's been reported that about 50% of hospitalized patients develop some degree of hypoxemia about a week into the course of their disease. And the imaging that you can see in these patients is sort of a spectrum that may range from ground glass opacities to denser consolidations, similar to what we see with classic ARDS. And typically we can see these peak imaging findings about 10 days into the course of the disease. There are cases where you can actually see these abnormalities on chest imaging even prior to the development of pulmonary symptoms. So patients may come in with vague symptoms or even GI symptoms, and a CT of the chest may show ground glass opacities consistent with viral pneumonia. Other things that can cause pulmonary disease in these patients are thromboembolic disease. So pulmonary emboli are not uncommon in these patients. We've seen patients present with COVID pneumonia in addition to pulmonary emboli at presentation, or develop thromboembolic disease sometime during the course of their disease due to either macro or microvascular thrombosis. So this is some images, CT images of the chest. And what we can see with COVID pneumonia is, in patients that have minimal symptoms, their imaging may be normal, especially those with mild disease. And then for those that have more moderate to severe disease, more classically, you'll see, as in the left upper hand corner, ground glass opacities. And then as the disease progresses or in more severe disease, you can see, as in the right and in the lower CT scan, denser consolidations, more classic of ARDS. And typically these consolidations or ground glass opacities are peripheral and bilateral, and you may see more of these densities in the bases of the lung. But as you can see, there is a spectrum of findings for the CT imaging. So, there really has been described this spectrum of symptoms in these patients that develop pulmonary disease due to COVID pneumonia. And patients may present with mild illness with no evidence of pneumonia. And in a study in Wuhan, they described the Chinese CDC reported that about 81% of patients actually fit this mild disease phenotype. And then others may progress to more moderate disease process where they have evidence of lower respiratory disease by clinical assessment or by imaging, but they may have no evidence of hypoxemia. And then there are those that develop more severe disease with tachypnea and worsening hypoxemia. And then a percentage of those that actually may progress to acute respiratory distress syndrome with this worsening pneumonia, progression of the inflammation, and what we've called the cytokine storm. What has been noted is that there are risk factors for more severe disease, and age has been reported as a risk factor in addition to underlying comorbidities such as diabetes, cardiovascular disease, cancer, and just to name a few. And in a study that looked at patients that died in Italy, the median number of comorbidities that was found in these patients was about 2.7. So it's really important to keep in mind that comorbid conditions do impact these patients. So this is just a representation. This figure represents the different phases of disease progression. And you can see in stage 1 of the viral infection, patients may have minimal symptoms, sort of vague symptoms. And then it's not really until stage 2 where you get the viral pneumonia and what's termed as the pulmonary phase. And these patients can present with some degree of shortness of breath. They may or may not be hypoxic depending on the severity of disease. And then in a percentage of patients, their disease progresses and they have this hyperinflammatory syndrome and develop acute respiratory distress syndrome and oftentimes multi-organ failure. And so with this worsening of the disease process and the worsening inflammation due to this viral pneumonia, patients have a loss of functional and residual capacity, not just due to the viral pneumonia, but also due to the dependent atelectasis. And many times you're seeing patients with this severe hypoxemia, which has been termed silent hypoxemia, because these patients are hypoxemic, but they don't feel like they're lacking air. So what's been described as far as the disease progression is oftentimes patients will present with vague symptoms that may progress over a week. And what's been reported in some of the Chinese studies is that usually dyspnea starts about six and a half days into the onset of the disease. And once dyspnea starts, if there's a progression to ARDS, that usually occurs pretty quickly. In the Chinese studies, they found that ARDS occurred in about 15 to 30% of their patients. And when we think about what percentage of patients are requiring critical care, there was a study in New York of about 2,600 patients that were hospitalized that were COVID positive, and about 14% of these patients were treated in the ICU, and 12% required mechanical ventilation. What's interesting is that in this study, they did report that of those that received mechanical ventilation, there was about an 88% mortality rate. And this mortality rate got a lot of hype in the media, and we got a lot of questions about, well, should we even be putting patients on mechanical ventilation? But there were a lot of issues with the analysis of this study, partly because this, when the mortality rate was reported, it only accounted for patients that died or that were discharged. So there was still a large number of COVID positive patients in the hospital that were not accounted for. In discussions with colleagues and other health systems, it seems that the mortality rate that we are seeing is about in about 30% to 40% range. So what do we see when these patients come into the hospital? So the initial phase is patients that may come in with a little bit of shortness of breath, maybe require about 2 to 10 liters of oxygen, have mild tachypnea, and their imaging will be consistent with bilateral ground glass opacities or denser infiltrates. And we have oftentimes been seeing a lot of these patients that have thick secretions that are very difficult to mobilize. And this phase of the disease can last for days. And then there are those that progress and have worsening hypoxemia with increased oxygen requirements in the 10 to 15 liter range. Their secretions are worse, their cough, they have to work harder to cough. And in these patients, they may have more subjective shortness of breath and more anxiety. And if you were to repeat imaging, you'd see more progression of consolidation, inflammation in these patients. And again, this phase can last for days as well, where these patients are requiring a higher level of oxygen. And at this point, this is when we should be thinking about managing these patients in the ICU as their disease progresses. And then a percentage of patients continue to progress to respiratory failure where they require either non-rebreather, high flow nasal cannula, or invasive mechanical ventilation. And initially, this respiratory failure is characterized by significant VQ mismatch. These patients may have denser consolidations. Initially, with the respiratory failure, we may see just a single organ failure with a lack of vasodilatory or cardiogenic shock unless there is a concurrent infection or a pre-existing cardiomyopathy. And oftentimes these patients may have waxing and waning of their fevers, and a percentage of them may progress to multi-organ failure, even though initially they only had a single organ failure. So this is what we're seeing with these patients that are being admitted to the ICU with respiratory failure. And so obviously the main driver of the respiratory failure is this severe hypoxemia. And the question is, what is the mechanism for this hypoxemia? And what we think is going on in these patients is twofold. So typically the in these patients initially, because of dysregulation of pulmonary perfusion, there is a significant VQ mismatch, which is causing hypoxemia. Ventilation in these patients usually isn't an issue. They have minimal dead space. Initially their PCO2 is typically normal and their minute ventilation is not elevated. Another driver of a hypoxemia is shunting. So if you look at the figure on the right here, with mild disease, as patients are given more oxygen, we see a response and an elevation of PaO2. And in those that have more severe disease, as the FiO2 is increased, we don't see an improvement and you see significant shunting. And in fact, a case series reported that shunt fractions were as high as 50% in these patients. So it's really important to keep in mind that there's two mechanisms of hypoxemia that are contributing, that are occurring in these patients, both VQ mismatching and shunting. And now I want to turn it over to my colleague, Dr. Miller, to talk a little bit more of the physiology of the lung disease that we're seeing and the management of the respiratory failure. Thank you.
Thank you, Dr. Esper. Is my screen shared?
Not yet.
Is it sharing now?
I can share them for you, Chad, if you need to.
Is it not?
We can see you, and we can see you've gotten out of your pajamas, but I...
You're lucky.
Yes, now we can see something.
Excellent. Okay, sorry for the technical difficulties, and I apologize for my paced speech. I'm trying to pick this up a little bit, given we're behind on time. So for those of you struggling with the postprandial food coma and you can't keep up, that's okay. We'll make our slides available. As Dr. Esper so nicely described the clinical presentation of these patients with SARS-CoV-2 viral pneumonia and some of the underlying pathophysiology, I'm going to move forward and talk about the zenith of respiratory failure in these patients and the form of ARDS, or acute respiratory distress syndrome. I put the Dickens reference there on the slide because, in fact, as Dr. Sabiri so elegantly stated at the beginning of the talk, that this viral pneumonia behaved physiologically very different than what we were traditionally used to. And in fact, what has been described in a lot of the work out of northern Italy, championed by Dr. Luciano Gattoni, kind of demonstrated this new phenotype or atypical ARDS. This new phenotype was described as being a more relatively normal lung compliance as opposed to the classic picture that we see where you have stiff lungs. But in general, the ARDS develops in about 15 to 40% of ICU patients with COVID-19. Obviously, that's varied from country to country and facility to facility. But these different phenotypes, again, have been contrasted. And as we can see, the classic ARDS, again, has a more recruitable lung where it's responsive to increased PEEP. It's noted in have increased left to right shunt. There's an association of increased mortality as well as multi-system organ failure. You may see this in literature referred to as the H type. The atypical ARDS, or relatively normal lung compliance, or L type, behaved vastly differently. The lung was less recruitable. In other words, there was a relatively decent aeration of lung. You didn't have this very consolidated, poorly aerated lung tissue as we see in more prototypical ARDS. In such that the PEEP was less effective in recruiting that lung, as well as improving oxygenation. And in fact, what we found is that high levels of PEEP in these patients with this phenotype often suffered hemodynamically, as the PEEP and increased positive pressure adversely affected hemodynamics in the right ventricle. The atypical ARDS phenotype also seemed to have a better outcome, as well as rather more rapid improvements in oxygenation. Unfortunately, those patients who presented with the atypical type phenotype, they would also sometimes still evolve into the more classic described ARDS picture. The reason for this is not clear. Some postulate some self-induced lung injury with patients generating massive amounts of intrathoracic pressure to increase oxygenation, and due to their normal lung compliance, that ultimately caused worsening, alveolar leak in the already extremely inflammatory milieu of the alveolar space in the setting of the pneumonia. Others postulated perhaps there was some vascular compromise, as Drs. Ross and Gadd noted, but why one evolves from one type to the other isn't clear. As you can see here, here's two CT scans representing the images of the different phenotypes. So on the top there, A, you have relatively sparse airspace disease, but as you can see, a PaO2 to FiO2 ratio of 95. The bottom screen, or B, is very densely consolidated with associated ground glass, and what we classically more think of as what a CT scan looks like with ARDS. Yet, the PaO2 to FiO2 ratio for that patient was 85, so almost identical. So though clinically, and as in defined by bilateral infiltrates, a PaO2 to FiO2 ratio that less than 200, these pictures are vastly different. They frankly look about as different as I do now compared to that god-awful picture that's on the e-flyer for this program. But by oxygenation and ventilation perspectives, they look identical. Here's a review of patients from Wuhan, a case series of 50 patients. And if you can notice that the compliance in the two groups is markedly different. Notice 42 versus 19.5. Again, the low end of normal lung compliance on a ventilator for an adult is about 50 millimeters per centimeter of water pressure. And notice that the PaO2 to FiO2 ratio between these two are almost identical. But if you compare the survival, notice that the survivors were markedly representative of the high compliance group, whereas the non-survivors had the low compliance. And that's a pretty big difference. That's been somewhat bore out in other case series. The prevalence of these subtypes does vary to a large degree. A series of 50 patients out of Wuhan, 40% of those patients presented with this atypical type ARDS. And then a series out of northern Italy, where a lot of this work was kind of initially done and put together. 50% of 150 patients were also demonstrating this high compliance phenotype. However, some series here, a case series out of Seattle, Washington, single hospital, the median compliance of those patients was 29. In a more recently published case series out of Beth Israel and Mass General, the median compliance of those patients was 35. So we are perhaps seeing an evolution of the kinds of ARDS that are being described that may be relative to some changes in strategy. That we may be now selecting patients in the ARDS phenotype due to some different kind of strategies as to who to use mechanical ventilation with and without. So as it turns out, given this difference in physiology, there may have been some opportunities to treat these patients differently. Certainly in our own institution, we initially were thinking that, as most others did, that all these patients should be intubated as soon as they become grossly hypoxemic, even though, as Dr. Esper described, many of them were fine. They were on TikTok before they got intubated. And as it turns out, they were probably representing that high compliance phenotype. And those patients do offer an opportunity for non-invasive positive pressure to recruit lung. These patients came into the hospital, they had viral pneumonia, they've been laying in bed, they've not been doing a cynospirometry due to the isolation, they haven't been getting up. And so they lie on their backs for several days with high fever, feeling terrible, and guess what? They would develop nonetheless some significant dependent atelectasis, and that would then drive their worsening hypoxia. And due to the fear of aerosolization, many of these patients were immediately intubated, and unfortunately that may have portended a worse outcome. And what it turns out is that the use of non-invasive positive pressure may be a real opportunity to recruit those relatively normal lung segments and stave off intubation. So CPAP, so relatively moderate pressures of 12 to 14 centimeters of water are reasonable places to start. And even if patients are highly hypoxemic, it would be reasonable to give them a trial of this therapy if their ventilatory status is relatively intact, i.e. their work of breathing isn't markedly elevated and they don't have significant dead space issues. BiPAP is a bit of a concern in these patients due to their high lung compliance. It's certainly an acceptable thing to try, but one needs to be careful because higher levels of IPAP with the normal lung compliance may yield some pretty big tidal volumes. And if you do that for a few days, you could ultimately induce volume trauma and put yourself right back in the situation of having ARDS. High flow nasal cannula is also an opportunity to provide positive pressure. But one important fact here is that you need to use high flow rates, at least of 50 liters per minute. If you look at data on what kind of PEEP that generates, it's varied. Some papers as low as 4.8, some as high as 7.2 centimeters of water pressure associated with that much flow. But the point is that you're providing some element of PEEP to the patient to help recruit those relatively normal lung segments that have become atelectatic. And then lastly, and kind of in tune with the non-invasive strategy would be high flow nasal cannula with awake proning. Interesting, there was a paper describing using this strategy in patients with acute lung injury prior to the COVID-19 pandemic. And what they demonstrated is using high flow and awake proning with relatively short cycle times. In that paper, it was about 1.8 hours twice a day. There were significant improvements in PaO2. Subsequently, and anecdotally with these COVID-19 patients, we've seen improvements in PaO2 by using awake proning strategies in patients that are on the floor even, let alone in the ICU. Mechanical ventilation, so these patients are sick enough to require mechanical ventilation. Again, we would urge the tailoring of ventilation management to the physiology it's represented. In other words, check their compliance. If the compliance is high or relatively normal and they seem to have that atypical phenotype, then maybe a slightly larger tidal volume than we're accustomed to may be an appropriate thing to use, i.e. maybe 8 cc's per kilogram per ideal body weight as opposed to the standard 6. Obviously, the caveat of maintaining a plateau pressure less than 30 is still important. And the idea is that perhaps you're doing a little bit better job of recruiting that normal lung. If they have obviously the more prototypical ARDS phenotype, then we need to stick to our guns and use what we know and more classic ARDS and ventilation strategies. The same holds true for the PEEP. Aggressive PEEP up to moderate levels following intubation to again try to recruit lung units to improve FRC. But be careful pushing it much higher as in this kind of high compliant atypical phenotype. What we've seen and certainly in our health system and others have recommended is continued liberal uses of PEEP to facilitate improvement in PaO2 to FiO2 ratios to combat the atelectasis and loss of FRC that often ensues during mechanical ventilation. And I think also just to remind that if you're going to use aggressive PEEP levels up above 14 to ensure that they in fact are that kind of prototypical ARDS phenotype where there is lung to actually recruit with increased peak levels. Additional treatment strategies, anybody watching who knows me would know that I wouldn't give a talk without trying to plug some use of a pulmonary vasodilator. And in fact, in ARDS and respiratory failure with COVID-19, there's opportunities. These agents will improve FiO2 and need and PaO2 to FiO2 ratios. They've all been looked at in prior and more prototypical forms of ARDS. There's nothing reported at present. There's a number of active small studies going on with pulmonary vasodilators. This include nitric oxide, inhaled epoprostenol, and inhaled iloprost. Obviously, proning on the ventilator is something that was employed prior to the pandemic. People with poor PF ratios. Using prone ventilation in both the atypical and typical phenotypes is reasonable. What you may find is that in the more compliant atypical phenotype that your proning cycle time does not need to be quite as long as you're, again, redistributing blood flow and recruiting normal lung units as compared to the typical ARDS proning strategy where you are prone longer because you're actually trying to recruit some of those very consolidated compressed elements of lung. And then finally, extubation and liberation from mechanical ventilation. Post-extubation decompensation was often attributed to atelectasis worsening hypoxia. And in a number of centers and a number of conversations and threads, there was jokes about no one gets reintubated without a trial of positive pressure. And what was described is that often these patients who, again, of that more classic, the more atypical ARDS phenotype, would be extubated, but then developed subsequent atelectasis due to poor inspiratory effort and become markedly hypoxemic again and be on the verge of reintubation. So aggressive use of positive pressure post-extubation has been an effective tool, as you can see, for a kind of variety of PF ratios, offered some potential strategies with high flow and extubation to CPAP. Again, there are papers that are referenced that demonstrate the utility of extubation to positive pressure in patients prior to the COVID-19 pandemic. I think it's just maybe employing those strategies a little more aggressive. And then, of course, as always, aggressive post-extubation incentive spirometry is extremely important, as well as trying to get the patient upright in a better breathing position. And with that, I will turn it back over to Dr. Sabiri.
Thank you so much for an excellent discussion of the management of respiratory failure. And our next speaker is going to be Dr. There you go. Our next speaker is going to be Dr. Mark Caridi-Scheibel. Dr. Caridi-Scheibel is an anesthesiologist by training. He's also undergone critical care training and training in ECMO. He is an assistant professor in the Department of Anesthesia at Emory University and the program director of the Anesthesia and Anesthesiology Critical Care Fellowship Program at that institution. Without further delays, I'd like to ask Dr. to present his case for management of shock in COVID-19. Thank you.
Hello, everybody. Thank you. Can you hear me okay? I hope. So I'm going to be just talking about managing shock in COVID. Get this going here. Again, I'm an intensivist in COVID units here. And just a couple caveats. I would say that data remains scarce on a lot of this. A lot of this is observational. And I'd also like to give a thank you real quick to our team best practice committee that has informed a lot of these protocols and observations. So, you know, by shock, just to reiterate, I'm talking about specifically hypotension with signs of end organ dysfunction. And I'm going to start with the statement that just says that COVID in and of itself does not produce vasodilatory shock. And we've seen this even with very high inflammatory markers. We've seen people even on nicardipine to keep their pressure down. What I would really say, what this means is that if you do see undifferentiated hypotension, it really requires a deeper level of investigation than just chalking it up to septic shock. I would also say as a preamble that rapid assessment and treatment is crucial, and that we should really have an algorithm to kind of run through things really quickly. There's a lot of confounders in COVID in kind of analyzing specifically septic shock, but also just trying to differentiate. While it doesn't produce hypotension per se, it does produce end organ dysfunction. So, you're going to see altered mental status, AKI, hepatic dysfunction, and cardiac dysfunction that may or may not even be in the presence of shock. Fevers are common, waxing and waning. The white count can be falsely reassuring because you can have leukopenia. QSOFA will be positive on everybody. CRP is uniformly elevated in everybody. And then there's the host of pre-existing conditions that people have, such as heart failure. So it's really important to have kind of a baseline picture as everybody comes into your ICU so that you know what changes exist. Knowing history of cardiac problems, we do baseline EKGs and if possible echoes on everybody, and then having a baseline set of labs, including troponin, central venous, a BNP, and a ABG with lactate. We monitor, we've been a little less aggressive here with daily monitoring. We still at a minimum get ABG with a lactate, a troponin, and a central sat. Most everybody who comes into the ICU, if they're on greater than 10 liters of nasal cannula, do get an arterial line, and that part of that's for easy sampling without having to have phlebotomy, and part of it is just not having to do procedures in a rush. But through all this monitoring, what your triggers for action should be are new and increasing pressure requirements, and we really emphasize to all the bedside providers, the affiliate providers, or the residents that any change in substantial change in pressure requirements really needs to prompt a discussion with the attending. New rhythm disturbances, especially ventricular disturbances, are ominous. Rising lactate, rising troponin, or a greater than 10-point decrease in the central sat that doesn't have a corresponding decrease in the arterial sat. Couple what we've kind of observed, in the very beginning, everybody was very concerned with an acute viral myocarditis, and I think the good thing about that concern was that it at least led us to be very observant and to be highly vigilant for what changes do occur. But by and large, we have not seen that. I would say in kind of in order of like prevalence, we've seen more acute RV failure from PE or progressive pulmonary hypertension from likely microthrombi. And that's probably been the #1 source of cardiogenic shock that we've seen. We've also seen, acute decompensated heart failure from pre-existing cardiomyopathy. We've seen new arrhythmias that maybe, just from being critically ill, such as AFib or some ventricular dysrhythmias. We've had a few MIs. And then we have had a couple kind of more explained unexplained acute cardiomyopathies that have been rapidly progressive. Some of this may just be from other septic sources, but we do hypothesize that there's microcirculatory damage, as the prior speakers have indicated, and likely global ischemic changes. But there may also be contributing this hypothesis of a cytokine storm, and then probably very lastly, a just true viral myocarditis, which really we have not observed, at least not directly. So in the evaluation, though, what I would say is of all the shock sources, the cardiogenic and embolic sources have the worst outcomes and are most rapidly progressive. So we generally assume the worst. If you have new unexplained shock, we assume it's cardiogenic until proven otherwise, just because it is associated with a high incidence of sudden death. The decompensation can be very rapid once the EF starts to fall, and you can really be doing other evaluations for your sepsis or whatnot, as you kind of move through the cardiogenic workup. We start with trending EKGs and troponins. Although MI has been observed, it's not that common, but it has been observed. And to that note, it also helps to have a kind of a pre-agreed upon plan with interventional cardiology for managing COVID patients in the cath lab. But by and large, echo has been sort of the most feasible and easily accessible evaluation in our COVID unit. We have designed kind of an evaluation algorithm mostly around echo, whether it's bedside or formal. The breakpoints here that we used were more or less arbitrary, but it helped us to have kind of a framework for what we were going to do next. So if on echo there's a normal heart or there's no change in overall in right or left function, we just kind of continue to monitor and continue with our normal sepsis workup. If we see an isolated decline in RV function, obviously there's a high concern for PE. We correlate it with other changes in the patient, and then it's a trigger to notify both our ECMO team and the PE team. And we also have a special hematology team now that we can seek guidance from. A moderately reduced EF is more a trigger to be a lot more hypervigilant. We do notify the ECMO team at this point, and again, trend labs, and really repeat an echo again in 6 hours, because when they do start to decompensate, they can decompensate over the scale of hours, not days. Anybody with a severely reduced EF, you really need to act on right away. It's a stat ECMO or shock consult for mechanical support, inotropes, and rapid anticoagulation. So just starting to think about treatment. For all etiologies, I would say early intercession is really key to kind of preventing their progression. The first, of course, is maintaining perfusion. Inotropic support, we have a low threshold for. We've seen people be pretty responsive to dobutamine. We avoid milrinone because so that it doesn't worsen the VQ mismatching with the pneumonia. Pulmonary afterload reduction. Chad, you'll be very pleased with this. Inhaled nitric or epoprostenol. And then restoration of a normal rhythm, amio or lidocaine, assuming drips. Aggressive electrolyte correction, therapeutic anticoagulation we use one of our triggers for therapeutic anticoagulation is unexplained kind of a progression of a refractory hypoxemia or other signs of microcirculatory damage, and we consider this to be one of them. And finally, we call our ECMO or shock management teams early if we think they're a good candidate. Etiology specific inotropes, for PE, initiation of inotropes, a low threshold for lytic therapy, even for submassive PE. Pulmonary afterload reduction, again, MI, we use our usual MI management, but again, have a plan, like a pre-existing plan with your cath lab for moving these patients efficiently into the cath lab. And instead, for all patients, if it's an NSTEMI where you might normally start like a low standard heparin, we consider full anticoagulation in a lot of these people. Cardiomyopathies, it's basic heart failure management, inotropy and volume reduction. But keep in mind when aggressive afterload reduction should be balanced with maintaining perfusion through organs which have a lot of high thrombus load. And then consider early mechanical support. And then for the severe cardiomyopathies, this is the point where you might want to consider rescue immunomodulator therapy like high steroids, the IL-6 inhibitors, or other emerging therapies. There's also, we've been considering using plasma exchange for these people. So, if you've kind of ruled out cardiogenic shock, there's just some kind of pearls on septic shock I'll share. What I would say is that, in the beginning, people were saying, oh, they can't have a bacterial infection because they presented with COVID. And, we did see quite a number of bacterial superinfections, probably again, because especially later on as people were staying home and kind of festering in their own secretions for a while. But I would say that if you have any sort of a septic shock picture, it should really prompt a search for a bacterial or a fungal source. Some of the classic signs, although I showed some of the other confounders, what I would say is that high venous sat is still indicative. Elevated lactate still indicative despite fluid resuscitation. High white counts are fairly indicative. However, be careful again with low white counts because it doesn't rule it out. They may just be leukopenic from the COVID. High fever is suggestive but not specific. You can see intermittent high fevers with just COVID. We found procalcitonin to be very helpful in distinguishing a superinfection from primary COVID infection. Treatment-wise, it's just good sepsis principles. Appropriate resuscitation, in the resuscitative phase, and then stopping. Pan cultures, and then rapid administration of the right antibiotic early. We've been going towards broad spectrum if they're in septic shock, and not trying community first. You can always narrow later based on your cultures. If there's not response, if the cultures remain negative and they're still in shock, we consider changing lines again. We've had a low threshold for fungal coverage, especially if they've had a prolonged ICU stay. For whatever, we've had a couple patients with either demonstrated candidiasis or a marked response to mycofungin. And so we've had a lower threshold for doing that. Stress dose steroids, I know there was some concern over using steroids early on in the crisis. Stress dose steroids have always been kind of an exception to that. And then, positive cultures help to narrow, but negative cultures, may kind of depend on the clinical picture. Other diagnoses to consider, hypovolemia and bleeding, especially we've been anticoagulating a lot of people. We've seen very few bleeds, but they have occurred. But these should be kind of diagnoses of exclusion. Autonomic dysfunction, we've seen there's some people who've just hung on to pressors for days and days and days without any clear etiology. And it's unclear whether this is autonomic dysfunction from either a neurogenic source or some sort of neurohormonal or nephrogenic or hormonal issue. And sometimes we've seen this accompanied by either tachycardia or bradycardic events. So it's all been kind of a picture with that. We have still seen run-of-the-mill decompensated heart failure or stress-related cardiomyopathies. But I would say in the end, our number one reason for pressor use specifically has just been sedation related. But again, that is a diagnosis of exclusion. So final thoughts, shock is atypical in COVID and really should be investigated deeply. COVID infection does not preclude co-infection. Cardiogenic shock is prone to rapid progression with a poor outcome. Oops, sorry. And vigilance and a rapid response are required. So finally, plan ahead. All right, and that is it. We have all of our protocols that I mentioned here available on our website.
Thank you so very much for that excellent presentation. And I apologize to everybody for not having kept you on the schedule, but thanks to Dr. Caridi, we will be able to entertain a couple of questions. I will exercise my prerogative as the moderator to choose a question each in each of these sections. So going to the first section, which was about hypercoagulability, there's a question asking about the similarity between what was described in pathophysiology and microangiopathic hemolytic anemia. Do you think we should expect to see schistocytes on smears and possibly need to manage similar to TTP with plasma exchange in certain patients, assuming of course that they do not have DIC? Dr. Gadd or Dr. Ross, do you want to address this?
Yeah, I don't know if Dr. Ross is still there, but I can try to address it. So that's a great question. I mean, that is one of the mechanisms perhaps that is responsible for hypercoagulability, refractory hypercoagulability in these patients. At this stage, I think it makes sense to be open to that idea. I don't know how it will pan out, how effective it will be, but here at Emory also we are keeping that option open for select patients.
Great. Thank you very much. Going to section number 2, my question is about the two phenotypes. Although they appear to be very distinct, in my personal experience, I feel that there is a combination of the two that can manifest itself as well. I'd like to know the opinion of our speakers, whether or not they have experienced the same thing as well. For example, in patients who are manifestly H phenotype, sometimes reduction of PEEP actually helps. So your experience.
I would concur in that sometimes even the H or prototypical phenotype ARDS patient doesn't really behave quite like you would expect a ARDS patient from, say, pneumococcal pneumonia would behave. I would agree with that some of the efforts seem to be either counter or just grossly ineffective. And these patients, further decompensate into requiring, mechanical circulatory support.
Great. Dr. Esper, did you have any additional comments?
Your question is about the PEEP responsiveness in these patients with the H phenotype?
Well, my question is that some of these patients, H phenotypes, may actually not respond to elevated PEEPs. And by the same token, the people who we believe are L phenotypes do better even when they are flipped over and proned. So correct. I suspect that the two phenotypes probably coexist in the same patient.
Right, and that's what when I've been asked about whether we've seen two distinct phenotypes, I've really seen more of a combination of those phenotypes. And so some of those that have more of the classic ARDS are not necessarily responding to higher levels of PEEP. And yes, those with not as much, don't have those denser consolidations or the H phenotype do actually do well with proning. So I think what we're seeing is rather than really two distinct phenotypes, really just a spectrum. And sometimes you'll see combination of both phenotypes in the same patient.
Great. Next question is for Dr. Karidi. Would you tell us about your ECMO experience? What are the outcomes? Because there's been much literature both ways, some claiming great success, others claiming that it should absolutely be avoided. So tell us about your experience with ECMO. Mark, you may have to unmute yourself. I wonder if we lost Mark for the time being. Let me go on to a different question. This is totally different from what we discussed today. This is very fascinating. Children seem to have severe inflammation without hypercoagulation. This is different due to the fact that children at baseline have low levels of coagulation cascade until they increase during adolescence. I know we don't normally treat children, not the panel here, but perhaps next week with our next talk, we will have somebody from the pediatric realm, and they may be able to address it if, unless Dr. Ross or Dr. Gadd want to take a shot at it.
Well, I can just share my thoughts. Yes, it is true that with advancing age, the risk of clotting increases because the clotting factor levels go up and the clotting cascade in general becomes more active. The balance between pro and anti-thrombotic factors is changed with age. But this is, I think, an interesting speculation. I also wonder, extremely inflammatory conditions like HLH, that's like the very extreme form of inflammation. We haven't seen this kind of coagulation in that population also. So I think it just is fascinating, the kind of hypercoagulability we're seeing in these patients. And I think there still is much to be learned.
Great. I'm going to take another question from this section because this section probably evoked the most interest. So there's a question about presentation of COVID with thrombosis, that is a patient presenting with a PE. Can someone address the issue of thrombosis at the presentation as a presentation symptom of COVID? There are a couple of questions in that of that type.
Yeah, so I'll take that. Definitely, there's been experience with patients coming in both China and in Europe with a manifestation of established PE at the time of presentation. In fact, the case I thought about presenting today was a case that did present with PE. You know, I think in these patients, their presentations are so diverse that they can perhaps be hypercoagulable and still relatively asymptomatic. We've had one patient present to Piedmont who presented with a DVT and no other symptoms. And just by a lark in the emergency department, the ED physician decided to test them and they tested positive, which represents something to think about in terms of safety when you're sending these patients to the vascular lab and other places. So in the hospital. So I think we really don't know. The sicker patients, of course, have a much higher chance of having VTE or PE if you look for it. But in terms of those being admitted, we just don't know yet the prevalence of established VTE.
Great. Thank you very much. We are on the dot at 2:30 now. And I want to thank all the faculty members who presented today for their time and their expertise, and all the organizers. And until next week, thank you very much and have a good day. Be safe.